Thank you everyone. Good morning. So my topic of presentation is anterolateral thigh flap. It's almost ideal soft tissue flap for the head and neck reconstructions. You know everyone knows the anatomy. The perforators are coming from the lateral circumflex femoral artery, the descending branch mostly. There are very vast indications for soft tissue reconstruction. I think in my practice right now, radial artery is only used for the tongue wide glossectomy. Is all these soft tissue defects are reconstructed with the anterolateral thigh flaps, posterior segmental mandibulectomy, ITF, then large parotid tumors. They are all even the large fungating lesion on the lateral aspect that is again reconstructed with the bipedal soft tissue flaps. A female patient with the near total glossectomy is a good soft tissue flap for this. Again, the small maxillary defects, you can do the intraoral resection and reconstruction. Orbital excentrations, then fungating neck nodes. So these are all the, there are many indications for the ALT. The most important, before we start off the harvest, the important thing is you have to be clear about the perforator selection. You should know what is the thickness required, what is soft tissue requirement, and the pedicle length. Most of the time for marginal, you require around 7 to 8 centimeter, but if you are doing maxilla reconstruction without any mandible involvement, you require around 9 to 10 centimeter of the pedicle length. Here you can see the patient has one good septocutaneous perforator, but I required a thin flap and the long pedicle length, so I choose the musculocutaneous perforator distally. For long flap, always the two perforators are better, so you have the flexibility of the inset. Then if it is not available, there are always option of the AMT flap or the TFL flap. And again, one important thing before is the always take a small cup of muscle till the perforator reaches to the main pedicle. Can you start the video? Yeah. Okay. So the standard marking from the ASIS to the this thing lateral border of patella. Then I normally take incision around 2.5 to 3 centimeter anteriorly. I always go from the anterior approach. Only be careful with the patient who lose extreme weight recently, because that time the septum might be at a different position. So better to do the Doppler before marking the incisions. And I take the Vicry's sutures. These help to retract the paddle laterally. Then you have to identify the rectus femoris muscle. Just apply a Babcock and retract it to medially. And always be on the muscle to avoid the damage to the septum that coming from the rectus and the vastus lateralis, and most of the vessels and perforators are coming through it. Once there is a sufficient place, you apply the right angle retractor and search for the perforator. If you see that it is a non-committal approach, I didn't take the proximal incision yet. Once I see the perforator is there, then I will mark the proximal this thing, because otherwise if there is no perforator, you will miss the TFL and other branches of the flap. So once you are confirmed that there is a perforator, you commit the incision, commit the flap. Again, the proper hemostasis is important because for a perforator dissection, this is the requirement, because if there is a bloody field, you can damage the perforator branches. So here there is a perforator. It has a small intramuscular course, and always check for the pulsations. So the ideal perforator is one which has a pulsation, which has a two vena comitant accompanying it, and again, as per your requirement, whether it is going to give a pedicle length and the thickness you required, because you can thin the flap, but too much thinning may lead to a marginal necrosis and all that. So it's better to uh, primarily take the, if you require a thin flap, go distally and you'll get the thin flap there. Once the perforator is decided, you try deroop the perforator in intramuscular this thing, because is I seen lot of variable anatomy in the ALT perforator. Sometimes the artery goes to somewhere, one vein is going somewhere, and other vein is joining some other part. So always deroop first. Even if you want to take the muscle with it, you can take it on the distal branch. Still, it's better to take a deroop the perforator, see the course, and then start dissecting the perforator. So you require a good bipolar and vascular forceps. That's all. So I marks the exact entry of the perforator, because that part of the flap should be at the center of the defect. Even for the bipedal, you can take the perforator at just near the commissure before this thing. If you have a single perforator, still you can manage with the deepithelialization. A bipedal defect can be managed, and you can take some extra flap on both sides if you required for the filling of the soft tissue. You can deepithelialize and fill all the dead cavities there. So I just committing the flap. Here is the most important thing. There should not be any excessive pull or traction on the perforator. So once you can do the dissection first and take the incision later on also, the posterior incision. So here I put the one drape there, just staple it with, staple the drape there on the posterior incision, and so the flap will be relaxed on that. There will not be excessive traction on the perforator. Now I start the distally. Sometimes you get some perforator there, so be careful on this dissection. And if there is no perforator, you can, once you reach towards the perforator, then start using bipolar. So from here it is once your perforator is identified, your perforator is derooped, just checking the pulsations, and you can see the pulsations in the perforator. Then I start dissecting from here till from one side, complete all the small branches you need to clip and free the pedicle. Now this part of the pedicle, still it reaches to the main vessels. I try to take a small cup of muscle, so it prevents the damage to the perforator and damage to mainly the small vena comitants of the perforator. So all these branches you need to clip properly. And if you want to take a muscle, you can take on the what is the distal branch coming from here. So you can take the muscle here. If you require to fill some soft tissue defect, you can take the muscle. Another important thing, the continuous irrigation. The vessel should not be dried. So this is the one side of the dissection. Then you do the once this side is complete, you go from the other side. For right-handed person, this is slightly difficult, this thing, but again there should not be excessive stretch on the perforator. So here I use the Babcock there, and with the cautery, bipolar cautery on the right hand, and using my little finger, I use the slight traction to the Babcock so that the you can see the branches clearly and ligate them properly. And once both sides are done, then you dissect from the base. Again, here you can use the Babcock to just retract the muscle laterally, so it opens up the plane between the this thing, and you can see the branches which are going perpendicularly into the muscles. You can see them more clearly, and we see the my left hand is holding the flap, so it's in total control of the traction. So I don't give flap or a retractor to the assistant. Assistant is only standing on the other side just to retract the rectus femoris. This is almost, and you can see there is a vastus, the now is totally preserved there. It should be preserved well. That vascularity also should be preserved. You should not hold it into the skin hook and retract here and there, and there should not be cautery burn on the now. So just before divided, you should always check for the bleeding, and I'll normally always check on the most distal part. If it is a bright red and slow, then you can go ahead with the other this thing. The final division. And the most of the time, donor site is closed primarily. If it is a septocutaneous perforator, no, not much muscular dissection. I normally don't put a drain unless there is a lot of intramuscular dissection. Then only I put the drain. You can see the nerve is spared completely. So this is how the donor site is closed in two layers with the vicryl and this thing. You can see the is my most favorite flap. I yet to lose the ALT yet, almost completing the 1000 ALT flap for head and neck reconstruction. Some publications from my department. And always thanks to my teachers for all the knowledge they given to me. Thank you.